Good morning. We are about to commence the first breakfast session of the Sri Lanka Surgical Congress 2021, and the first session will be on the cardiac masterclass, and I invite Dr. Gnanakanthan to commence the discussion. Over to you, Dr. Gnanakanthan.
My talk is going to be on the aortic root replacement. Yeah, my topic is going to be on the aortic root replacement. I will follow the following subtitles in my talk. And first of all, I will elaborate some anatomy of the aortic root, and then the causes of the aortic root dilatation, the aneurysm, and indications for surgery. And the following that, I'll be mainly considering about the valve conduit replacement, that's the Benton's operation, and then few things about the valve sparing aortic root replacement. While mentioning about the surgical treatment, I will provide some tips and tricks. So what is the aortic root? The aortic root is a structure, actually it is within the center of the heart. It embraces by the tricuspid valve anteriorly, and then the pulmonary artery and the pulmonary valve, and the mitral valve on posteriorly. So the aortic root is a structure which is from the aortic annulus up to the sinotubular junction, where it becomes an ascending aorta. So it comprises the aortic leaflets as well as the sinuses of Valsalva as well. So when you look at the anatomy, the aortic root is made of 3 circular rings and then 3 semicircular crown-like rings. And here you can see the green color one is what we call a virtual ring, which runs along the nadir of the aortic valve leaflets. And above that, about a couple of millimeters above, there is what we call an anatomical ventricular arterial junction, where it is the ventricle meets with the aortic wall. And the topmost one is called what we call a sinotubular junction, where it becomes the aortic root becomes ascending aorta. And there are 3 semicircular rings, which are the attachments of the aortic valve cusp. So what are the investigations we do? So mainly the easiest one is and available everywhere is a chest X-ray, and chest X-ray might be normal because since the aortic root is going to be in the center of the heart, if it is only the root is dilated, the chest X-ray might be normal, or if it is ascending aorta and even the arch are involved, then what happens is the mediastinal widening would be there. And the next investigation is the transthoracic echo and the transesophageal echocardiogram, and the transthoracic echo, which is useful to measure the sizes of the aortic annulus here, and then the aortic sinuses and the sinotubular junction and the ascending aorta, as well as the functional assessment of the heart, where how the aortic regurgitation, whether there are any aortic stenosis, and then how the function of the left ventricle. And this is a transesophageal echocardiogram, and where you can, during an intraoperative period or even a preoperative assessment, you will be able to exactly measure the sizes of the dimensions of the aorta. And then the CT aortogram or MRI aortogram, which is useful in planning out the surgery, because in the echocardiogram we can say whether there is a dilatation, and then the functional assessment and the extent of the aneurysmal dilatation cannot be assessed properly with the echocardiogram alone. So therefore, we need to have a CT aortogram prior to surgery. So in a CT aortogram, where we will be looking at not only the aortic root, we will be looking at the epi-aortic vessels also, where the brachiocephalic, left carotid, as well as the left subclavian, where does it arise from, whether there is a common origin, or whether there are any anatomical variation or anatomical abnormalities, which will be helpful in planning out surgery and how to cannulate and where to cannulate for the surgical procedure. So what is the pathophysiology behind the aortic aneurysm is there are two mechanisms have been postulated. One is what we call congenital aortic fragility from the genetic predisposition. And the second one is called what we call a mechanical stress, where there is always a stress inside the wall and which will expand the aorta. And the other one postulated was the aortic media affected by damage and repair events. Usually there is always a damage and repair events which occurs, but in some patients, if there is excessive injury, that could be because of the valve dysfunction, hypertension, or because of the degeneration, age-related degenerative procedure, or there might be causes for what you call a impaired repair, where there is a connective tissue disorder, underlying connective tissue disorder is there. So when we consider the etiology of ascending aortic aneurysm, and most of in the elderly people, it is what we call degenerative aortic aneurysms. And there are other causes in young patients when they are presenting in the early 20s or the early 30s. They are usually associated with some sort of syndromes. Mainly the Marfan syndrome, Loeys-Dietz syndrome, Ehlers-Danlos, Turner or Noonan syndrome. Those are the patients they usually present. And in some of them, though they don't have any syndromes associated with their disease process, but there is a family history. Some families also, it runs in the family. And then what we call a bicuspid aortic valve is one of the most commonest cause in the younger patients, because bicuspid aortic valve, it increases the stresses on the wall in the ascending aortic and then the aortic root. So they present very early either with aortic regurgitation or with the aortic stenosis or associated aortic valve disease, like in rheumatic aortic valve disease or something, and the aortic stenosis is there. Then you get due to the mechanical stress, you might have a post-stenotic dilatation. So how are we going to manage the ascending aortic aneurysm? Are all patients need surgical treatment? No. So it all depends on how the size and how the function of the valve. So some of them, if the size is small, what we need to do is we have to manage them medically only. We don't need to operate them. We can keep them on a follow-up with imaging techniques every yearly or maybe every 2 yearly. We'll have to follow them up if the size is not reached to the surgical interventional area. So, or otherwise, we'll have to look at the predictors of complication. Then leaving the aortic aneurysm in some patients with a lot of comorbidities is much better than operating them, because when we operate with a lot of comorbidities, then there will be mortality and the morbidity would be high. So we'll have to look at the predictors of complications such as the aortic dissection and the aortic regurgitation and then the rupture. And then we'll be going into the treatment of surgical treatment indications and what type of surgery what we are going to do. So indications could be, we can make it broadly categorized into the elective surgical procedures and for the emergency procedures. The elective surgical procedures, indication for elective surgery in ascending aortic aneurysm, where there is degenerative aortic aneurysm. So in those cases, the aortic diameter is more than 55 millimeter, and we will be looking at, and because these are mainly associated with very elderly patients, we'll have to evaluate their comorbidities and the benefit versus risk of surgery. So if the risk of surgery is going to be, say, it's an octogenarian who is having an aortic aneurysm about 55 or 60 millimeters, but with a lot of comorbidities, it's better we can manage him with a medical treatment with the beta blockers and the blood pressure control. But at the same time, but if it is in a younger patient, it would be better to offer him surgery. So here you can see, these are the two pictures. There is the aortic root is dilated. Here you can see the CT scan, the aortic root, and then the proximal ascending aorta is dilated, but the rest of the things are normal. And the indication in elective surgery in Marfan syndrome. The Marfan syndrome is different entity. So in those cases, we usually tends to operate little earlier than the degenerative aneurysm. Usually the cutoff point is 50 millimeter. But in some cases, we will be offering them surgery even less than 50 millimeters, the 45 millimeter, if there is risk factors like sort of first degree family related with the acute ascending aortic dissection or rupture, or there is a concomitant indication for valve surgery, like sort of they have a severe AR, left ventricle is failing. So in those cases, or even if it is a smaller diameter, in the children, especially, you will have to look at the ratio of the aortic diameter to the body surface area. If it is more than 2.75 centimeter per meter in children, then that is indicated. Or if the expansion rate of more than 3 millimeter per year. So the other indication is if in the females, if they want to become pregnant after marriage, so in those cases, we will be offering them surgery even less dimension, like in about 40 millimeters. And other common cause is a bicuspid aortic valve. The bicuspid aortic valve also is almost the diameter for the elective surgery is about 55 millimeter as in a degenerative aneurysm. But in some cases, then we will be offering them surgery if they have a coarctation which is being corrected or not being corrected, because they are more prone to have dissection. And then the first degree family related with acute dissection or rupture, if they are smaller body size, like in a Marfan's, if they have a smaller body size, then we'll have to look at the diameter and body surface area ratio. And if there are associated other valve problem, like sort of aortic stenosis or aortic regurgitation, that needs operation because of their symptoms or the deteriorating LV function, in those cases, or the expansion rate is 2 millimeter per year. The other indication is the diameter more than 45 millimeter. If we are going for an elective surgery, like sort of if somebody is having a coronary artery disease who needs a coronary artery bypass, in those patients, we will be offering even if it is 45 millimeter in size. So when you look at this flow diagram, then if it is a dilated ascending aorta, if it is less than 55 millimeters, or in a 50 millimeter in Marfan's and bicuspid aortic valve, there we will be only medical treatment and serial imaging follow-up only we will be doing it. But if it is more than 55 millimeter or 50 millimeter in Marfan's and bicuspid, the surgical treatment offered, whether there is the aortic root is dilated. If it is aortic root is dilated and with a normal valve, then we will be going for a valve sparing root replacement. But if it is a structural damage to the valve also, then we will be offering them a composite graft valve replacement. But if the only ascending aorta is involved, then it's only the tube graft on the supracoronary part. So as I mentioned, then those are the indications for elective surgical intervention. But there are emergency surgical intervention. There is a type A aortic dissection, where there is extensive dissection involving both coronary arteries, and then the aortic sinus is disrupted. In those cases, with the aortic root dilatation, they need to have aortic root replacement. And the third emergency indication is infective endocarditis. Either it could be a native or a prostatic valve endocarditis. Usually they have a severe disruption with the aortic root abscess and heart failure. Usually they prevent heart failure. So in those cases, also they need a aortic root replacement. But in this situation of infective endocarditis, it is better to offer them with a homograft. So now we will get on to the surgical technique. So the aortic root replacement is usually done with 3 axis thing. So usually what my practice is the standard median sternotomy. It could be a long sternotomy or maybe a short sternotomy, either whichever is comfortable with you, or maybe a upper mini sternotomy or right anterior thoracotomy. I don't have any experience in right anterior thoracotomy, but so here the incision usually it's extend from the suprasternal notch up to the cipisternum, but depending on the experience, the incision size can be smaller. And then each and every step of surgery is very important, and then the meticulous hemostasis is the paramount importance in aortic surgery, because and here you can see this is a median sternotomy is being done, and then you can apply the bone wax to the bone, or some people they don't apply the bone wax at all, but make sure that you have adequate hemostasis, and the retractors are placed at the middle third and the lower third area, so to prevent the brachial plexus injury. The mini sternotomy, usually the upper mini sternotomy is the one with the extension into the third or a fourth intercostal space is being done. Here you can see that there is upper upper mini sternotomy had been done, and we have been using a normal retractors in these patients, but there are commercially available specific retractors for this, because that is very useful, because the arms will be away from the surgical field. And once we have done the median sternotomy, the next step is to opening the pericardium. The opening the pericardium, as it is in a usual coronary artery bypass, we will be opening in the midline with an inverted T incision. And here, usually where the cranial end, the pericardium is started reflected on from the distal ascending aorta or the arch of the aorta. So you don't need to cut up to that point. You can cut slightly shorter than the pericardial reflection, so that when you hitch the pericardium, it will give you a nice seal from the outside the pericardium, so that the blood won't seep inside the surgical field. And then the pericardial reflection and even the incision depends on where you are going to cannulate, what the cannulation technique is going to be offered. So sometimes if it is an arch is also being involved, so in those cases we have to cannulate the brachiocephalic artery or the right axillary artery or a femoral artery. So the cannulation site varies. And if the arch also needs to be replaced, so then our incision has to be extended into the neck as well. Here, these are the things what I mentioned, that the pericardial reflections are being sutured to the skin edges, so that make sure that we don't get any blood spilled into the surgical field. So it keeps the surgical field clean and nice. So these are the some of the pictures which I can show you. This is what we call aortoannular ectasia, where only the root is dilated. And here you can see there is a typical Marfan syndrome, where the root is crustally dilated, almost the size of the LV, and which measured almost 8 centimeters in diameter. So this is again another case where you can see only the aortic root is dilated. Ascending aorta is relatively of normal size. These are different pictures which I'm just trying to show you how the pericardial reflection is being attached to the skin. And once the pericardium is hitched to the skin, then we have to mobilize the structures. There are 2 ways of doing it. One is before you go on bypass, you can mobilize the structures, especially the ascending aorta and proximal arch, from the pulmonary artery and then the right pulmonary artery, main pulmonary artery and the right pulmonary artery. But there are, in cases, especially in the redos or sometimes the inflammatory aneurysms, there is a lot of adhesions around the aorta and the pulmonary artery. So in those cases, it's better to delay the mobilization of the structures till we go on cardiopulmonary bypass. And then once we have adequate mobilization is done, we are ready, then we can ask the anesthetist to give heparin and start doing the ACT. And the other issue is, and then the cannulation is most important thing. Where do we want to cannulate? So is it only the aortic root is going to be replaced? Is it the aortic root plus the arch, or whether it's a hemi-arch, whether the complete arch is needed? So depending on the type of surgery we are planning, so the cannulation site varies. Usually aortic cannulation, I prefer to do either in the ascending, for the aortic root replacement, either in the distal ascending aorta or the proximal arch, where I usually uses the straight aortic cannula, where we can adjust the length which is going to be inside the arch of the aorta. So in those cases, we can use either the SANS or a FemFlex Edwards cannulation we can be used. And the venous cannulation is usually with a single double stage cannulation through the atrial appendage is sufficient. But in cases where we need a associated or accompanying other valve surgery like sort of mitral or a tricuspid needs to be replaced in those cases, or if it is a small children, then we might have to go with the bicaval cannulation. And the cardioplegia also, better to have the antegrade as well as the retrograde cardioplegia, especially in the Marfan syndromes. And then in some patients with the degenerative aortic aneurysm, their main issue is aortic regurgitation. So in those cases, we may not be able to give the cardioplegia to the root. And right superior pulmonary vein vent can be used. Here you can see the aortic cannulation in the distal aortic aorta. Then I'm putting a purse string into the distal ascending aorta. You can go as distal as possible. Sometimes it is easier in a Seldinger technique where you can use, like in a femoral arterial cannulation, where you can use a needle, puncture, and then the guide wire and serial dilators, and then put the cannula. So that is easier, especially if it is an arch. If you are going to cannulate the arch, that is the most easiest thing. And here you can see there is a left superior pulmonary vein purse string is inserted. I usually do this procedure once I have started on a cardiopulmonary bypass. Only I started, or some people even before they do it, there is a risk of air embolism if you do it, if the air gets sucked into the circulation. So as I mentioned, the cardioplegia, antegrade cardioplegia, either we can give it to the root if the aortic valve is competent. If the aortic valve is incompetent, we can fibrillate and then open the aorta and give the into the coronary ostia. Preferably, better to use the antegrade as well as the retrograde cardioplegia because the cardiac protection is much more effective in both antegrade and the retrograde. And at the same time, the retrograde have the advantage of, because you do not need to sort of interrupt your surgical procedures to give cardioplegia in between. So if you have a retrograde cardioplegia while you are doing a coronary buttons and dosing, you can ask the perfusionist to give the retrograde cardioplegia. So once the cardioplegia is given, then the aneurysmal resection and the mobilization of the coronary button. That's the next important thing. So I don't have the pictures to show you. What we do is we usually make a longitudinal incision and then look at the right coronary button. Because especially in the Marfan syndromes, the aorta is grossly dilated and then the right coronary button is mobilized more cranially. So if you cut low down, you might damage the right coronary artery. So it's better to have an incision fairly high and longitudinal incision and look inside the aorta to see the right coronary origin and make a larger button. Initially, you can take a larger button of the right coronary as well as the left coronary and then make them on a tracking stitch so that the orientation is in a correct place. So then the valve cusps are excised and then you have to place the aortic annular sutures. The annular sutures are like in a aortic valve replacement, but here you use 26 millimeter polyester sutures with pledgets. The pledgets, I usually keep them outside, that is on the aortic side, but some people usually they keep it in the ventricular side. But if it is going to be valve sparing root replacement, these sutures has to be in the subannular place where the pledget would be sitting on the ventricular side. Here you can see the pledgets are all outside. And once you have done that one, and then we'll have to measure the valve size. And there are valve conduits available with custom pre-made ones. or otherwise we'll have to custom made ones. So usually what happens is if the valve size is either 21, we take a graft 5 millimeter, 5 millimeter size greater than the valve. Then it will nicely fits into the valve conduit, and then you run the 4 sutures or 3 of proline sutures along the valve edges. Or some people, what they do is they don't run along the suture, they take the valve sutures through the valve plus the conduit. And at the other technical tip is where if you are going to suture that valve, here I don't know whether you can appreciate, then I have everted the last 3-4 millimeters of the conduit before putting the stitches. So these, what do you call it? It is called a French cuff technique, where once you have finished anastomosing the bottom end, what you can do is you can take this edge and then the rest of the annulus, and then you can run along with the 4 sutures so that the hemostasis is more secured. This is a ready-madely available valve conduit, with the onyx conduit with the Valsalva. You can see, and once the valve sutures are being placed, now it's passing along the circumference of the valve conduit. Like it in the aortic valve, you just pass it all around, equally spaced all around the valve conduit. And once it is being done, then it is being parachuted down. And once they are parachuted, here there is a small tip is there, because usually if the valve is tightly fitting, sometimes once you start tying from the left coronary cusp and the right coronary cusp, when you come to the non-coronary cusp, the valve sits above the annulus and it's difficult to push it down. So to prevent that, what I usually do is I usually take a snugger, 1 or 2 snuggers, and snug them on the non-coronary and the right coronary before started tying it. You can see there is a snugger here, which is being used for the non-coronary area, and I usually start tying from the left coronary cusp. Any side is okay, but I usually start from the left coronary cusp and come along the clockwise manner and to finish it with the non-coronary sinus. And once we have done the proximal anastomosis, then our attention has to turn to the reimplantation of the coronaries. And that is a most important aspect of this surgical procedure. If you have not properly anastomosed the coronary, then the coming off it would be a problem and there will be an ischemia. So the first is the left coronary button, and the left coronary button, you can see now the conduit is there. It's been sort of turned caudally, and then pull the conduit and then pull the coronary button also and see where it lies nicely without any kinking or without any stretch. And then you can use electrocontouring or maybe a number 11 blade and make a circular incision where you are going to have a coronary button. And if it is in the Marfan syndrome, it's better to have a smaller coronary button possible. And like that, and the right coronary also, you will have to do it on the right coronary. And the right coronary, usually what happens is it is in a Marfan and then a grossly dilated aortic root. The right coronary button, usually you have to implant them fairly more cranial than expected. Otherwise, what happens is the coronary gets kinked because once you have resected the aneurysm, then there is a long length of coronary is there. So then once the aorta also distance, it tends to kink, and then you won't be able to come off bypass. And then the graft length measurement. Usually we are very scared about whether the graft is going to be short. Most of the time the graft won't be short. It is more lengthier than what we expect. So for the graft to anastomose, assess the size and the length of the anastomosis, what we have to do is we have to stretch the graft so that the corrugations are under stretch, and then cut it little shorter with the greater curvature side. It's more lengthier than the lesser curvature side, so it has to be slightly oblique, and then you start the distal anastomosis, and the distal anastomosis, either you can use 4-oproline or a 3-oproline, which is comfortable with you, and depending on the tissue type also, whether it's a fragile tissue, it's better to go for a porous sutures with the Teflon felt on the aortic side. And once you have finished that one, then we have to DAR the cardiac chambers, and at the same time you can ask, while you are doing a distal anastomosis, you can ask the perfusionist to rewarm the patient, and make sure that always put pacing wires before taking off the clamp on right ventricle, because the distension of the heart after taking off the cross clamp is more dangerous and more detrimental to the outcome. So in those cases, I usually place 2 pacing wires and connect it to the pacing box and make sure that it is being working, and then you can sort of blow on lungs and then take the cross clamp off. And as usual, then once the cross clamp is off and the DARing process is done, then the temperature has come to a normothermia about 36, and make sure that the blood gases are okay, and rest of the things, and then there's adequate perfusion and adequate ventilation, and the heart rhythm is normal. You can then, once the heart started beating, and then you can remove the pacing and see whether it is in the sinus rhythm or whether you need to have a pacing backup or whether it needs to come off with the pacing. So depending on that, and then you can routinely wean off from the cardiopulmonary bypass. And the most important thing in aortic surgery is the hemostasis is the most important thing. And for that, it's a meticulous technique. Each and every stitch has to be placed under vision, so that you prevent any bleeding, post-operative bleeding, or maybe a hematoma formation. And in some of these cases, better to use because the aortic root, where once it is the cross clamp is off and the heart started beating, it is inside, it goes inside. You won't be able to see any suture lines most of the time. So because of that, make sure that it is bone dry, and then you can apply some glue. Bioglues are available, Tissile is available, you can apply glue, and then give protamine. And sometimes if it is a longer procedure, you might have to give the plasma and the platelets, and then pack it and patiently wait for 4 or 5 minutes before taking all the pack. You don't need to sort of remove the packs every second and see. You have to pack it and then leave it for some time, and most of the bleeding, it will settle on its own. So this is a picture at the end of the surgery. You can see that how the conduit is lying with a nice curvature, and the hemostasis is also fairly adequate. I have just put everything, and only the swab is there. It's not getting wet. And this is another picture where you can see the nice curvature of the aortic root plus the proximal, even though it has gone, it's a hemi-arch procedure. We have gone up to the proximal arch. And as I mentioned that this I don't have a picture, the video. This is a picture which is showing the tissue valve also can be hands-on into the valve, either it's in the Valsalva graft or in a normal tube graft, where the sizes are usually there are 5 millimeter difference is there between the conduit and the valve. And this is a post-operative CT scan where you can see the conduit, how nicely it is. Here you can see the Teflon felt which is around there. And then the valve sparing aortic root replacement, there are 2 types. One is by Dr. Jacob, it's what he called Sir Magdi Jacob procedure, where you excise only the valve sinuses, only you will be excising, and then we resuspend the valve into the curvature where we have cut into this one and then suture along that. And the other one is what we call David's procedure, where we usually keep the valve inside and then the suture lines goes below the annulus. Here you can see it. This is a David's procedure, and this is McDiaco's procedure, where valves are resuspended inside the conduit. David's procedure, we re-implant it, and the Jacob's procedure, we resuspend them. For the completeness, there might be cases where we have to redo surgery. So the strategies of redo surgeries, we have to first thing is a re-entry. Either they have had aortic valve earlier, or sometimes they would have had another procedure, or maybe a root itself. So then the root is going to be very difficult. So the strategies are where we have to first re-enter safely, and then we have to institute the cardiopulmonary bypass, and then the myocardial and the brain protection comes if we are going to have the epiaortic vessels also needs to be implanted. So the standard precautions during the chest re-entry are, we should always have a defibrillator pads ready and attached to the patient. And the sternal wires, either you can remove the sternal wires and then use an oscillating saw, or some people untwist the sternal wire and leave it intact so that it won't go beyond the posterior table, and keep the blood pressure less than 100 millimeter mercury. You might be able to use some GTN to vasodilate them and put them on anti-Trendelenburg positions, and always make sure that the cardiopulmonary bypass circuit is ready on table before the skin incision is made. Thank you.
Thank you, Dr. Nyadakantan, for your excellent presentation. Due to some time constraints, I think we'll have to wind up our session with this presentation only, but there's some time for questions from the audience. So if there are no questions from the audience, I would like to ask one thing from Jnana. How do you select patients? For you mentioned about valve sparing surgeries. How do you select patients for valve sparing surgeries rather than going for a Bentall procedure?
The valve sparing surgery, especially it's for younger patients, and where the valve, macroscopically, the valve is competent. In those cases, it's better to go for a valve sparing surgery. But the only issue is the valve sparing surgery in the bicuspid aortic valve. There are chances that they will degenerate later, then they will come for a second surgical procedure in future. And in our sort of setup, the second surgical procedure is very difficult. So in those cases, I think better to offer them the Bentalls itself, or if they want to become pregnant, or if a younger patient, and if they are involved in competitive sports, in those cases where the valve is macroscopically normal or maybe minimal aortic regurgitation, where you can preserve the valve and repair the aortic valve, in those cases I would prefer to go for a valve sparing replacement. And there are also either it can be a Maktu-Yakub procedure where you can resuspend it or reimplant it. And there are literature say the reimplantation is technically, though it be difficult, but longevity wise it's better than the resuspension.
Okay, since we are running out of time, if there are no other questions, we'll wind up these sessions. And I would like to apologize for the delay in, there was some little bit of a technical glitch when we started. So the other presentation on mitral valve repair, and we'll be doing these presentations again in our association academic sessions again. So you all are welcome to join these meetings again. So I would like to thank Dr. Nyadakantan for his excellent presentation, and we'll wind up this session. Okay, thank you.
Good morning, ladies and gentlemen, and welcome back to the Sri Lanka Surgical Congress 2021. You have joined Hall B on the post-T session on day 1. We're about to commence the Symposium 2A, titled Surgeon's Role in Preservation of Renal Surgery. May I hand over the chairpersons of the session, Professor Neville D. Pereira and Dr. Suren De Silva, to commence the symposium. Over to you, sir.
Good morning. We are into the second symposium for the day, and it's an interesting topic, the surgeon's role in preservation of renal function. Let me introduce Dr. Taha Mustafa, a consultant neurological surgeon working at the Nuwara Hospital. Over to you, Taha.
Morning, everyone. Thank you very much for that introduction. Many thanks for the organizing committee for giving me a chance to talk on this topic, prostatic obstruction, when to refer. Benign prostate obstruction. There are two components causing benign prostatic obstruction. The first one is static due to increased amount of prostate stroma. The second one is dynamic, which we may tend to forget and do not appreciate it. There's an increase in the amount of alpha-1 receptors in the stroma of the prostate and the smooth muscle of the prostate as well as the bladder neck. These two together will increase the outflow resistance. After some time, due to bladder remodeling, which we'll talk in a while, there's reduction in the bladder tone, the detrusor become unstable, and there's reduction in detrusor contractility. What about renal failure and benign prostate obstruction? There are changes occurs in bladder due to long-standing obstruction. Deposition of connective tissue initially started as collagen type 3. Later on, it is replaced by type 1 collagen. There's increased expression of myosin heavy chain. Percentage of connective tissue increases with regard to smooth muscle. This leads to bladder wall fibrosis, and there are areas of recurrent ischemia reperfusion injury. Ultimately, there is untoward fibrosis. Because of that, formation of trabeculation, reduction in bladder wall compliance, high post-void residual volume, the bladder will become low volume, high pressure component. Ultimately, patient will develop urologic obstruction and renal failure due to high back pressure at the glomerular level. In order to understand preservation of renal failure in prostate obstruction, we have to understand the prevalence of renal failure in prostate obstruction. Community study says 2.4% prevalence due to prostate condition. If the patient comes to prostate operation, when comparing to patient presenting to non-prostate operation, there's high incidence of renal failure. When the patient has high serum creatinine level, 1/3 had hydronephrosis. When the patient has uremic symptoms, more than 90% had hydronephrosis. Having said that, the extent of the association of the hazard ratio is not well established. But these are strong predictors to tell the patient that they will develop disease progression and renal failure. BUG obstruction, chronic retention, unstable detrusor, recurrent episodes of UTI, hypertension secondary to obstruction causing nephrogenic diabetic insipidus. It's proved in literature association of these predictors, specifically post-void residual volume more than 200 to 300, maximum flow rate less than 50 mils, Qmax, prostate more than 40 cc, PSA more than 2, was associated with renal failure in benign prostate obstruction. So if we get a patient with these numbers, we want to warn ourselves as well as the patient, there's a chance of disease progression and renal failure, so that we have to treat them accordingly. Bit of nomenclature, prostatism is obsolete. Histological diagnosis of BPH together with clinical diagnosis of BPE can cause benign prostate obstruction, but that is a urodynamically confirmed diagnosis. In other words, patient with BPH might not have clinical BPE, symptoms of prostate obstruction, or even urodynamically proven blood outflow obstruction. Due to this, the guidelines also changed. They started with treatment for benign prostate hyperplasia, but now they talk about management of non-neurogenic male lobe duct symptoms, including benign prostate obstruction. So we have to treat the patient's symptoms and the bother rather than the prostate enlargement itself. Prostate enlargement, it's a process of aging. So when the patient gets older, there is increment the size of the prostate, and there is a deterioration of the symptom score, as well as there is reduction in maximum flow rate and voided volume as well. Again, the risk of disease progression related to prostate size, maximum flow rate, PSA level, and the symptom score. You can appreciate that if the patient has moderate symptoms to start with, there's a 25% of having surgery or ending up in surgery in 4 years follow-up. Whereas if they have CPS symptoms to start with, this percentage goes up to 39. Let's have a look. What are the complications can occur in benign prostate obstruction? First and foremost is the retention, defined as inability to empty the bladder completely. It can be acute, chronic, or acute on chronic, depending on the presentation. Associated pain, the amount of residual urine, and the other symptoms like nocturnal aneurysms will differentiate this acute or chronic retention. Chronic retention, specifically defined as more than 300 mils of residual urine if patient can pass urine, or the patient cannot pass urine, it is defined as residual volume more than 1 liter. Pathological post-void residual volume, a vague definition, but most of them agree with it should be less than 1/3 of the bladder capacity. Late onset nocturnal aneurysms, unless proven otherwise, should be treated as chronic high pressure, chronic retention in men. Acute urinary retention is a painful, palpable, percussible bladder when the patient is unable to pass urine. This is the definition given by International Continence Society. It can be either spontaneous or precipitated due to pain, infection, or post-op. It is very important to differentiate because 3/4 of patients with spontaneous acute urinary retention may end up in surgeries, whereas in precipitated, it is only up to 25%. Trial without catheter can be done after starting after blockers in 1 to 3 days. Nevertheless, we should keep in mind 50% of men will have another episode of acute urinary retention over the next year, and 1/3 of men will require surgery within 6 months. So these patients will want to continue adequate treatment sometime, refer to their specialist. These are the patients who may fail trial without catheter, increase high age, post-void residual more than 1,000 mils, enlarged median lobe, spontaneous acute urinary retention, UTI, prolonged catheterization. What about chronic urinary retention? It is defined as a non-painful bladder which remains palpable or percussible after the patient has passed urine. Depending on the subtractive detrusor pressure at the end of maturation, it can be either low pressure chronic urinary retention or high pressure chronic urinary retention. The management differs for each. High pressure chronic urinary retention end up in surgery, but some of the low pressure chronic urinary retention we may be able to manage with clean intermittent self-catheterization. Altogether, 25% of chronic urinary retention patient will end up in outflow tract surgery. High pressure chronic retention, a hot topic. How do they present? Universally, tense, non-tender palpable bladder. Two-thirds of them will have the late onset aneurysms, and 80% will have hydronephrosis and hydrolytic with uremia. Half of them will have high blood pressure. Nevertheless, it will drop once the bladder is drained. High pressure chronic retention is due to bladder wall thickening, smooth muscle hypertrophy, infiltration of connective tissue, causing functional ureteric orifice obstruction or vesicular-ureteric reflux. So if we have patient with refractory acute urinary retention, high pressure chronic retention, or chronic urinary retention with high residual volume or repeated retention, they should be referred to specialist care to consider blood outflow tract surgeries. Other than the urinary retention, these are the other scenarios where the patient should be referred to specialist. First one is hematuria. There may be underlying carcinoma, should be investigated, or even though if it is due to benign prostate hyperplasia, it can be managed with surgery, which has 90% success rate. The other indication is UTI. As there is abnormal anatomy due to obstruction, it is always considered as complicated UTI. Stagnant urine acts as a growth medium for bacteria. So these patients should be managed initially for infection, but ultimately they will end up in outflow tract surgery after referral. Bladder calculi, benign prostate obstruction patient, they have 8-fold risk of developing calculi due to stagnation because of high post-residual volume as well as recurrent urinary tract infection. Prostate cancer, you have to ask always whether the index patient has a prostate cancer. As DRE has high false negative, if we have a doubt, patient should be referred to a specialist for further evaluation and treatment. Let's have a look what are the guidelines says. NICE, Canadian Urological Association, they say patients should be referred to a specialist if they have complication of benign prostate obstruction. Furthermore, AUA, European Urological Association, repeat the same. Specialists should see the patient when the patient has complication of benign prostate obstruction. On the other side of the corner, Japanese Urological Association, urological referral should be done if the patient has visible hematuria, abdominal GRE, urinary retention, recurrent UTI, and elevated PC. South African Urology Association tells the same, refer to surgery if the patient has BPO with complication. Such proper and timely referral of the patient to the specialist to deliver the correct treatment will be beneficial for the patient as well as the health system. Patient will benefit definitely if they have clear indication for outflow tract obstruction and they will have unobstructed urine flow like this. Thank you very much for your patience.
We move on to the next speaker. He'll be Dr. Nishantha Lienapathirana, consultant urological surgeon from the teaching hospital, Anuradhapura. Over to you, Nishantha.
Very good morning to all of you, and thank you very much for joining in. And I'll be talking about the management of small ureteric stone in view of best preservation of the renal function. So stones can destroy kidneys, and unfortunately, the acute care team who manage the colic might not see the full picture, which we will see in long-term follow-up of these patients. So my today's talk will be outlined into several categories. So I'll be talking about what are the options available for us to manage the calculi, ureteric calculi, and how to select the best out of them. And then the recent evidence of the medical expulsion therapy, and the ideal treatment duration, and what happens in prolonged obstruction in terms of renal functions. So, as you all know, the ureteric colic is probably the commonest of the acute abdomens which we see in the casual surgical unit. And it's quite important to have a clear outline of the management when it comes to the ureteric colics. So once you manage the acute presentation, once the patient's pain is settled, so we have to decide on which options we should select for these patients. It could be either conservative, which includes the medical expulsive therapy, or it could be interventional or an active intervention, such as shockwave lithogrypsy or stenting or primary ureterovenoscopy with laser lithogrypsy. So how do we select in between medical therapy or an interventional therapy? So it depends on the various factors, which could be categorized as stone-related as well as the patient-related. So the stone-related factors include size and the site of the stone, and also the degree of obstruction. And what about the patient-related, which includes a symptom severity and pain control, as well as the renal functions and the complications. So we take one by one, and we go through the best recommendations. So how do we assess the stone size? So we all know the best assessment of the stone size is the non-contrast CT-KUB. And unfortunately, but due to the financial limitations and the unavailability, we can't offer CT-KUB for all of our patients who comes with ureteric colic. So the next best options we have is the ultrasound scan and the X-ray KUB. Ultrasound scan is highly operator dependent investigation, and unfortunately it has some disadvantage of over and underestimation of the stone size. But if you combine it with the X-ray KUB, digital one, it will give us a more of a better combined picture, which would be ideal in our setting. So if you take an imaginary case where a person presented with a left-sided ureteric colic and you do an ultrasound scan, which shows left-sided hydronephrosis, and there's no mention of the size of the stone, you do an X-ray KUB. Here you can see a small, less than 1 millimeter size distal ureteric stone, which is the ideal case for medical expulsion therapy. But the same patient, if you do an ultrasound which shows left-sided hydronephrosis, then you do X-ray KUB, you see this. There's a large left upper ureteric stone. And, you know, trying them or giving them a trial of medical expulsion therapy is a complete waste of time. And of course, which makes their renal function going to get deteriorate in the long term. So one practical advice or the tip when you're assessing the size of the stone is to look at the height of the lumbar vertebra. Usually in adults, it's around 2.5. So if you compare the height of the lumbar vertebra with the size of the stone, you can have a rough assessment of the size of the stone. So we live in the era of evidence-based medicine. So if I have to influence your practice, I need to bring you the evidence. So let's just talk about some of the evidence in the medical management of the stone disease. So what is the best size for the medical expulsion therapy? So this is a very high quality study published in the European Radiology with the stone size assessment by a CT-KUB. Here you can see both the upper ureteric stones and the lower ureteric stones. The stone passage rate almost becoming zero when the stone size goes above 8 millimeters. So when the stone size reaching more than 8 millimeter, it is increasingly unlikely to pass spontaneously. So that's the evidence we have about the stone size. What about the location? So the evidence shows compared to a proximal ureteric stone, the distal ureteric stone is has 3 times higher chance of spontaneously pass when you start the medical management therapy. So when you're dealing with a proximal ureteric stone, it's always handy to keep that in mind, that there is a 1/3 of chance of passing that compared to a distal stone. So what's the recommended medication for the medical expulsive therapy? So when you bring the current available evidence, in 2015, when they published the data of the SUSPEND trial, the urology world took by a surprise. And this is a sort of high quality multi-center randomized placebo-controlled trial, which of course shows there's absolutely no difference between a placebo and a tamsulosin or an alpha blocker in terms of stone expulsion rates. However, there are a couple of glitches in the study, especially when you think about the stone size selected, and majority of the stones were around 4 millimeter, which of course will pass even if you don't treat with anything. So thereafter, there are so many studies which sort of assess the efficacy of various agents, including nifedipine and various other alpha blockers, all of which shows some good evidence that the medical expulsion therapy has a clear benefit compared to a placebo. So then in 2018, a Cochrane group published a very high quality study in terms of meta-analysis, and which shows a clear benefit of the tamsulosin or an alpha blocker. And the European Association of Urology have a strong recommendation of the alpha blocker therapy for stones more than 5 millimeter in size. So how long should we treat them in terms of medical expulsion? So if you look at all the available literature, 30 days is the mark which is given. So you can see all the charts when so if you take an imaginary case where a person presented with a left-sided ureteric colic and you do an ultrasound scan which shows left-sided hydronephrosis, and there's no mention of the size of the stone, you do an X-ray KUB. Here you can see a small, less than 1 millimeter size distal ureteric stone, which is the ideal case for medical expulsion therapy. But the same patient, if you do an ultrasound which shows left-sided hydronephrosis, then you do X-ray KUB, you'll see this. There's a large left upper ureteric stone. And, you know, trying them or giving them a trial of medical expulsion therapy is a complete waste of time. And of course, which makes their renal function going to get deteriorate in the long term. So one practical advice or the tip when you're assessing the size of the stone is to look at the height of the lumbar vertebra. Usually in adults, it's around 2.5. So if you compare the height of the lumbar vertebra with the size of the stone, you can have a rough assessment of the size of the stone. So we live in the era of evidence-based medicine. So if I have to influence your practice, I need to bring you the evidence. So let's just talk about some of the evidence in the medical management of the stone disease. So what is the best size for the medical expulsion therapy? So this is a very high quality study published in the European Radiology with the stone size assessment by a CT KUB. Here you can see both the upper ureteric stones and the lower ureteric stones. The stone passage rate almost becoming 0 when the stone size goes above 8 millimeters. So when the stone size reaching more than 8 millimeter, it is increasingly unlikely to pass spontaneously. So that's the evidence we have about the stone size. What about the location? So the evidence shows compared to a proximal ureteric stone, a distal ureteric stone is has 3 times higher chance of spontaneously pass when you start the medical management therapy. So when you're dealing with a proximal aortic stone, it's always handy to keep that in mind, that there is a 1/3 of chance of passing that compared to a distal stone. So what's the recommended medication for the medical expulsive therapy? So when you bring the current available evidence, in 2015, when they published the data of the SUSPEND trial, the urology world took by a surprise. And this is a sort of high quality multi-center randomized placebo-controlled trial, which of course shows there's absolutely no difference between a placebo and a tamsulosin or an alpha blocker in terms of stone expulsion rates. However, there are a couple of glitches in the study, especially when you think about the stone size selected, and majority of the stones were around 4 millimeter, which of course will pass even if you don't treat with anything. So thereafter, there are so many studies which sort of assess the efficacy of various agents, including nifedipine and various other alpha blockers, all of which shows some good evidence that the medical expulsion therapy has a clear benefit compared to a placebo. So then in 2018, a Cochrane group published a very high quality study in terms of meta-analysis, and which shows a clear benefit of the tamsulosin or an alpha blocker. And the European Association of Urology have a strong recommendation of the alpha blocker therapy for stones more than 5 millimeter in size. So how long should we treat them in terms of medical expulsion? So if you look at all the available literature, 30 days is the mark which is given. So you can see all the charts when the time window reaching the 30 days, the passage rate will reaching 0. So anything more than 30 days is not recommended. So what happens if the obstruction goes untreated and if you don't relieve the obstruction? Well, there are so many animal studies which shows unilateral obstruction is going to clearly cause declination of the renal functions. For obvious ethical reasons, we don't have that sort of studies in humans, but this is one of the best available studies where they have assessed, which of course shows there's absolutely no difference between a placebo and a tamsulosin or an alpha blocker in terms of stone expulsion rates. However, there are a couple of glitches in the study, especially when you think about the stone size selected, and majority of the stones were around 4 millimeter, which of course will pass even if you don't treat with anything. So thereafter, there are so many studies which sort of assess the efficacy of various agents, including nifedipine and various other alpha blockers, all of which shows some good evidence that the medical expulsion therapy has a clear benefit compared to a placebo. So then in 2018, a Cochrane group published a very high quality study in terms of meta-analysis, and which shows a clear benefit of the tamsulosin or an alpha blocker. And the European Association of Urology have a strong recommendation of the alpha blocker therapy for stones more than 5 millimeter in size. So how long should we treat them in terms of medical expulsion? So if you look at all the available literature, 30 days is the mark which is given. So you can see all the charts when the time window reaching the 30 days, the passage rate will reaching 0. So anything more than 30 days is not recommended. So what happens if the obstruction goes untreated and if you don't relieve the obstruction? Well, there are so many animal studies which shows unilateral obstruction is going to clearly cause declination of the renal functions. For obvious ethical reasons, we don't have that sort of studies in humans, but this is one of the best available studies where they have assessed two group of people, patients who's got iatrogenic renal obstruction by means of ureteric obstruction, were treated less than 2 weeks duration and were treated more than 2 week of time frame. So all these patients were treated less than 2 weeks. When you follow them up, they haven't had a significant hypertension, whereas more than 2 weeks it's got associated with the higher rates of long-term hypertension. And of course, in the second chart, when they follow up these kidneys with the nuclear scintigraphy, higher the duration, lesser the renal function, or the declination of the more the declination of the renal functions in the scintigraphy study in long-term follow-up. So that's the available evidence for obstruction. And what is the molecular mechanism for obstruction causing renal injury? So when there is a hydronephrosis, renal tubular epithelial cells will secrete inflammatory cytokines, and these things will attract more inflammatory cells and active fibroblasts, and the fibrin deposit and the collagen deposit will cause glomerulosclerosis, and that will in turn cause permanent renal injury. So when should be a patient referred for intervention? There are two indications. Number one, failed medical therapy. So you give them 30 days of medical expulsion therapy, and all the evidence shows beyond 30 days, there's hardly any benefit of continuing the same thing. And of course, we all know that the obstructed infected system. So these are urological emergencies, and these systems has to be drained within 12 to 24 hours in terms of stenting or a percutaneous nephrostomy. Otherwise, the permanent renal injury can cause. So what are the available options for the failed medical therapy, or if you decide for a primary interventional therapy? We all know that the modern day lasers have really improved in such a way. They're very highly effective and highly efficient, and they can be incorporated to a modern day ureteroscopies, which are quite slender and tiny. And in combination of laser and the ureteroscopy, nowadays we can treat any stone anywhere in the urinary tract. It could be in the ureter, it could be in the various part of calyx. It's just a matter of minutes. You can just go there and just laser them. And most of these patients can be discharged on the same day as a day case surgery with the very minimal complications. So key points or take-home messages. Ureteric calculi should be treated as individual case-based manner. So it has to be assessed individually with the various characteristics which we discussed before deciding on what is the best way of managing them. And also, the early intervention is always better than late, and delaying the treatment and continuing the obstruction will cause irreversible renal injury. And thank you very much for your kind patience.
Our next speaker, Dr. Kalana Paranapalya Guruge, will talk to us about minimal invasive surgery for renal stones and the role of renal preservation. Thank you.
Good morning, everybody. Let me congratulate the College of Surgeons of Sri Lanka on their Golden Jubilee anniversary. And on behalf of Sri Lanka Association of Urological Surgeons, it's my honor and privilege to present my talk on minimally invasive surgery for kidney stones at the Sri Lanka Surgical Congress 2021. Recent advancements in technology has paved the way to increase the options available in the management of kidney stones. The management decisions are tailor-made according to the anatomical location, stone size, complexity, density, as well as patient preference and local expertise. Kidney stones were historically treated with open surgery. They were managed in the recent past by shockwave lithogrypsy. Nowadays, minimally invasive modalities such as antegrade and retrograde endoscopic interventions are commonly used and widely accepted. Shockwave lithogrypsy is still suggested by the guidelines to be used in stones smaller than 2 centimeters. Although once popular, now it's losing the popularity due to the limitations. Shockwave lithogrypsy is better avoided in hard stones, lower calyceal stones, impacted stones, and infected stones due to the risk of sepsis and in morbid obesity. Retrograde intrarenal surgery, or RIRS, can be used as primary treatment in patients with kidney stones smaller than 2 centimeters. RIRS can be utilized safely in many instances where shockwave lithogrypsy has been unsuccessful. New miniaturized flexible ureterorhinoscopes as small as double J stent and effective holmium and thulium lasers have revolutionized RIRS application in treating kidney stones. Innovations in auxiliary equipment for easy access and stone retrieval has made RIRS more effective. Percutaneous nephrolectomy, PCNL as monotherapy provides the most successful stone-free rates in a single setting compared to both RIRS and shockwave lithogrypsy. Percutaneous nephrolectomy remains the a variety of rigid and flexible nephroscopes are available to be selected by surgeon's preference. The standard access tracts are 24 to 30 French. The renal access tracts are miniaturized. Now the mini perc is from 14 to 20 French. Ultra mini from 11 French to 13 French, and the micro PCNL, the tract size is 4.8 French. The guidelines may incorporate these changes in the near future. This slide illustrates the miniaturization of the access sheaths and selection of flexible and rigid nephroscopes available for PCNL. New technological advancements have improved both safety and efficacy of PCNL. 3D CT reconstructions have been used to improve planning the surgical approach in PCNL. A variety of energy sources are available for stone fragmentation. Pneumatic, ultrasonic and electrokinetic lithotripters, as well as holmium and thulium lasers. The advancements in the ancillary devices provide easier renal access, tract dilatation and stone retrieval. This short video demonstrates the pneumatic lithotripter and holmium laser in stone fragmentation during PCNL. Traditionally, a wide bore nephrostomy is kept at the end of PCNL, but mostly nowadays they are totally tubeless. Conventionally, patients are kept in prone position, but nowadays the patients are kept in various positions during PCNL depending on the individual case. Supine PCNL has provided easier anesthesia and improved patient safety. PCNL has providing emerging evidence to suggest when it's carried out under regional anesthesia and performed as a day case provides more safe, successful and cost-effective treatment modality in kidney stones. Bilateral synchronous PCNL provides simultaneous clearance of renal stones in both kidneys in a single setting during same anesthesia. Endoscopic combined intrarenal surgery or ECIRS provides simultaneous antegrade and retrograde access to the renal stones for better efficacy. Challenging renal anatomy and in morbid obesity, PCNL has proven better patient outcomes compared to open surgery. First CT image shows a stone in a calyceal diverticulum which is symptomatic and was successfully treated with mini PCNL. Second and third CT images shows complete staghones treated successfully with PCNL in a single setting. This slide shows bilateral renal stones treated with PCNL in single setting, bilateral synchronous PCNL. First image is of a horseshoe kidney. Second shows bilateral staghones with right upper ureteric stones. Third image shows right side complete staghorn and left side recurrent renal stone at the PUJ obstruction, and this patient had previous open surgery and you can see the lax abdominal muscles. In this slide, the first two intraoperative images show the different placement of percutaneous needles in bilateral synchronous PCNL based on variations in pelvic axial anatomy. The third image shows access tracts soon after completion of stone retrieval in bilateral synchronous PCNL. The last picture shows the puncture size and the scar after mini PCNL. High rate of surgical complications, negative impact on renal functions, prolonged hospital stay, delayed patient recovery are making open surgery a less attractive choice for treating renal stones. Miniaturized, minimally invasive modalities, both RIRS and PCNL, with newer improved energy devices provide shorter operative times, minimal operative complications, shorter hospital stays, and rapid return of patients to their routine activities, making it beneficial economically when compared to open renal stone surgeries. Globally accepted treatment of choice for renal stone is minimally invasive. Compromised renal function, high rate of surgical complications, prolonged hospital stay, and delayed patient recovery are not in favor of open renal stone surgeries, rendering it obsolete. The unavailability of minimally invasive equipment, lack of surgical experience, and patient preference should not be taken as indication for open surgery for renal stones. In Sri Lanka, urological services are widespread and at easy reach for patients in need. Thank you for your kind patience.
Thank you, Karana.
Our next presenter is Dr. Balasingham Balagopi, Senior Lecturer and Consultant Urological Surgeon from the Teaching Hospital, Jaffna. He'll be talking to us about nephron sparing surgery for renal cancer. Over to you.
Welcome to the Symposium on Surgeon's Role in Preservation of Renal Function. I'm going to present on nephron sparing surgery for renal cancer and surgeon's role in preserving the renal function. I'm Dr. Balagopi, a consultant urological surgeon. You all know that renal cancer is one of the deadliest cancer among urological cancer, and is the seventh most common cancer overall worldwide figures. But if you take the UK Cancer Network, it is a fifth most common cancer. And the incidence of renal cancer is rising, mainly because of more imaging and more incidental diagnosis of renal cancer, mainly the small renal mass. At the same time, the incidence of chronic kidney disease is rising worldwide. And this is a data from the Kidney International that's indicate almost 100% increase in the incidence of renal cancer, renal disease, chronic kidney disease from 1990 to 2016. If you take the surgical management of renal cancer, we have two main options. One is a partial nephrectomy, where we remove the cancer and leave a lot of nephrons with the patient. But radical nephrectomy, we remove the kidney with the cancer and with a lot of normal nephrons. So partial nephrectomy is indicated for a T1A and some T1B, where the tumors are larger in size, and rarely for T2 tumors. For the larger tumors or complex small renal masses, they need a a radical nephrectomy. There are other options for small renal masses where the tumor size is less than 4 centimeter. We can deal with ablation by cryotherapy or radiofrequency ablation, or we can go for active surveillance. When we are managing the renal cancer, we have to balance two things. One is the oncological safety and less surgical complications on one side. Other side, we have to balance the renal function preservation. So this study does indicate that cancer-specific survival and the recurrent-free survival is same or almost similar in nephron-sparing surgery, the radical nephrectomy. So when we considering the cancer-specific survival, the partial nephrectomy and radical nephrectomy is same. And the partial nephrectomy is oncologically is a safe procedure. In radical nephrectomy, we are losing a lot of nephrons. More nephrons we lose, patient can already establish patient the CKD can get worse CKD. They can get the advanced stages in the CKD. And some patients, they were previously normal renal function, can develop a new CKD. And it's proven beyond doubt that incidence of CKD in long run is more in radical nephrectomy. The probability of reduction in the renal function is more in radical nephrectomy than the partial nephrectomy. As in partial nephrectomy, we preserve a lot of nephrons. The incidence of reduction in the renal function is minimal when compared to the radical nephrectomy. There's a large cohort of randomized trial, 30,000. The partial nephrectomy patients have a better eGFR in long run when compared to the radical nephrectomy. A meta-analysis of 40,000 patients, CKD profile is better in partial nephrectomy. So the incidence of significant chronic kidney disease is more in radical nephrectomy than the partial nephrectomy or nephron-sparing surgery. The Lancet 2012 published this data. When we are doing renal cancer management, they estimate reduction in renal function. In active surveillance, we are not losing any nephrons. In partial nephrectomy or the minimally invasive treatments, we are losing roughly about 10% of nephrons. But radical nephrectomy, we are losing 30% of the nephrons. You might ask, why not 50%? Because when we are losing the one kidney, we should lose the 50% of renal function. But after radical nephrectomy, there are some functional adaptation in the kidney, like hyperplasia of remaining nephrons and hyperfiltration. So the renal function reduction is only 30% rather than 50%. When we consider more about nephron-sparing surgery or in the partial nephrectomy, we remove the tumor with a margin of normal tissue. At least a one-cell line is important. But some people do enucleation when the patient have a multiple small tumors. But that's even oncologically safe. So what are the standard indication for nephron-sparing surgery? There's an absolute indication when someone have a one kidney, we have to go for a partial nephrectomy. Otherwise, patient will end up in lifelong dialysis or renal replacement or renal transplant after 2 years. But there are relative indications for the renal cancer, like CKD patients or bilateral tumors, or people with the von Hippel-Lindau syndrome where they develop bilateral tumors. The elective indication is any T1A or T1B, some T1B, and rarely some T2, where we can go for a elective partial nephrectomy and their renal function is normal. So here you can see a patient with a solitary kidney, with a tumor, imperative indication for a partial nephrectomy. Patient with a bilateral tumor, a tumor here and tumor there, a relative indication for a partial nephrectomy. Von Hippel-Lindau, multiple tumors, they can develop tumors in the other kidney, or maybe they can have a synchronous lesion in bilaterally, another relative indication for a partial a nephrectomy. Sometimes they have a one kidney, the tumor, other kidney is contracted, or small kidney, again a relative indication for a partial nephrectomy. Now, what the EAU guideline says is offer partial nephrectomy to patients with T1 tumor. That's a strong recommendation. And they have say, even with some T2 tumors, if possible, technically feasible, go for a partial nephrectomy. That's a weak recommendation. There maybe you might get a larger tumors like T1B or T2, a low-lying fluid, the lower pole, easily you can go for a partial nephrectomy. So partial nephrectomy, not only for a T1A or small renal mass, we can go for a T1B and rarely some T2 tumors. Now, this is a New England Journal article that has said a patient with CKD have a more risk of cardiovascular death than a patient without CKD. Even in the CKD, more low in the GFR, you have a more relative risk of cardiovascular death. So if you take a mortality or other cause mortality other than the cancer, CKD patients have more risk of developing mortality than non-CKD patient, even though it's a common sense, that's evidence. But surgically made CKD have a better long-run profile than the medical CKD. Annual reduction in the eGFR in medical CKD is roughly about 5%. But annual eGFR reduction in surgical CKD, mainly the donor nephrectomy, is less than 1%. So the surgical CKD is better than the medical CKD. But we have a problem. We can't compare the surgical nephrectomy and donor nephrectomy when a patient with the renal cancer nephrectomy, because about 26% of renal cancer patients already have a eGFR less than 60. So they have already have a CKD. And renal cancer patients have a intrinsic glomerular pathology. They have already well-developed glomerular pathology in histologies when compared to the donor nephrectomy, because donors are healthy patients. Here we can see the other cause mortality. It's more in radical nephrectomy when compared to the nephron sparing surgery. So as a surgeons, we have to prevent a patient with a normal renal function developing a renal impairment. That is known as primary prevention. That's doing elective nephron sparing surgery for small renal mass. And also we have a role to prevent already CKD patients like stage 1 and stage 2 developing a more severe CKD like stage 3 and stage 4. So the patient with CKD and renal tumor, better to go for a nephron sparing surgery. There is a relative indication for nephron sparing surgery. By doing that, we are doing a secondary prevention of CKD. So as a surgeons, by doing elective nephron sparing surgery and relative and absolute indications nephron sparing surgery, we can do a primary and secondary preventions in regards to CKD. When we do a radical nephrectomy, there's loss of 30% function in the kidney. At the same time, if they have a medical disease, each year they lose about 5% of the eGFR. So in 6-year time, they will lose about 30% of the nephrons. So they lose about 60% of the nephrons in 6 years. But if you do a partial nephrectomy, there's a 10% nephron loss. Plus, if they have a medical disease, they can lose 30% of the nephrons. So not only doing a nephron sparing surgery is important, we have to manage the medical disease as well. So to preserve the renal function, we have to minimize the nephron loss by doing a nephron sparing surgery. That's one important thing. And we have to avoid nephrotoxic drugs like NSAIDs. And third, and most important thing, we We had to optimize the management of diabetic and hypertension and cardiovascular disease. Otherwise, they will lose 5% of the nephrons each year. So in conclusion, when we compare the cancer-specific survival, partial nephrectomy and radical nephrectomy is same. Kidney disease is more in radical nephrectomy than the partial nephrectomy. Chronic kidney disease increases the mortality due to the cardiovascular disease. Risk of CKD is more in renal cancer patients than the KT donors. Renal cancer patients, about 25% have already well-established CKD. So when you compare the overall survival in a renal cancer patient, better to go for a nephron-sparing surgery than the radical nephrectomy. Thank you.
Thank you, Balagopi, for that very elaborating and thought-provoking presentation. Now we are open for questions. Either you can send it, you can type it and send it to us, or you can ask us directly the questions. Anything to clarify from any of the presenters? I hope the presenters are with us live or live stream or?
Yes, sir, we are here.
Yeah, okay.
We can hear.
Okay. So let me, while we are waiting for the questions to come in, can I start with Balagopi? It's a very interesting point that the kidney donors, your comparison between the kidney donors and the tumor nephrectomies. Is there any scientific explanation for why the kidney donors, apart from these 26% of people with renal cancer having already established CKD, if it's a healthy kidney in a young person, doing a partial nephrectomy and a radical nephrectomy, how does it differ from a donor nephrectomy?
It's a good question. When you take renal cancer patients, they have some sort of risk factor like a diabetic, hypertension, or smoking. There was a study, big study, they did a biopsy or histological assessment of the normal tissue in a partial nephrectomy. They have found a lot of people have a glomerular pathology, like glomerular sclerosis in a patient with the renal cancer. So what they say is when you are doing a nephron sparing or surgical made CKD by doing a radical nephrectomy or partial nephrectomy, they have a bad prognosis when compared to the nephrectomy, donor nephrectomy, because their kidneys are, their glomerulars are very healthy. So they don't have any other risk factors.
Right. Yeah, I think there's a growing body of evidence. It's not being established yet, but to take EGFR, a critical EGFR, to decide whether to do a partial or a radical nephrectomy. In practice, it's always good to preserve the renal mass, but if the EGFR is normal or over 60, do you think that there is a difference between the long-term outcome between partial and radical nephrectomy? Say EGFR is 90 or 80 or 90?
That's a good question, sir. There is a study saying if a patient have a normal renal function, that is especially the EGFR is more than 60, doing a partial nephrectomy or radical nephrectomy is not going to change his overall survival.
Yeah, because that might have some legal implications. I think that's why I want to sort of highlight that point. Going to Kalana. Kalana, what's the place of laparoscopic stone surgery, laparoscopic pyrolithotomy? I think you were explaining it very nicely about the minimal invasive endoscopic surgery. Is there a place for laparoscopic renal surgery?
Yes, sir. Laparoscopic and robotic renal surgery has a place, but it's less cost effective, as well as on the patient side, it's the minimal invasive techniques far more superior than that. Actually, I haven't mentioned it in the in my presentation. In the guidelines also, it says that it has limited value in stone surgery.
Okay, thank you. I think, do you have any questions? Yeah, okay. Right, in the... Yeah, I think we are not getting questions from the audience. And I think the presentations were so clear and succinct that probably the facts were very clear to the audience. So in the absence of any more questions, I think we will conclude this session. Do we have any more time to wait, or? Do they send the questions here to the right. Yeah, so there's no questions, that means. Right. So in the absence of any questions, let me thank all the 4 speakers who did an excellent job this morning, highlighting on 4 important areas in urology and updating our knowledge on those areas, and very evidence-based presentations. And I hope that the listeners, and in future, I think there's a recorded, probably people can listen to it again, in which case I think people who have not participated in this symposium also would benefit from these presentations. Thank you very much and for these presentations, and enjoy the rest of the conference.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.